Introduction. Myotonia is a condition affecting skeletal muscles, characterized by prolonged muscle contraction after stimulation. This stimulation can be mechanical, electrical, or voluntary. Myotonia is classified into dystrophic and non-dystrophic forms. Non-dystrophic myotonia includes conditions caused by abnormalities in chloride channels, known as myotonia congenita or MC, and sodium channels, known as paramyotonia congenita. Myotonia congenita specifically results from a mutation in the CLCN1 gene, which is responsible for encoding voltage-gated chloride channels in the sarcolemma of cats. These chloride channels are essential for muscle relaxation. The mutation reduces inhibitory signals, thus hindering the muscle's ability to relax properly. Muscle contraction is triggered by sodium influx through acetylcholine ligand receptors and voltage-gated sodium channels. Repolarization and subsequent muscle relaxation occur through potassium efflux via ADP-dependent potassium channels. CLCN1 voltage-gated chloride channels facilitate chloride influx and efflux, contributing to a significant portion, about 80%, of inhibitory membrane current. When these CLCN1 channels are dysfunctional, there is reduced chloride permeability and increased membrane resistance, leading to decreased inhibitory currents. This imbalance causes the prolonged muscle contraction observed in myotonia congenita, leading to muscle stiffness and hypertrophy with runs of action potentials. Clinical signs of myotonia congenita in affected animals become apparent when they begin to walk. These signs can include muscular hypertrophy, dysphonia, blepharospasm, a protruding tongue, a stiff jaw, hyperextension of the limbs, falling over, and a stiff gait that tends to improve with exercise. These symptoms may worsen with excitement or exposure to cold temperatures. Diagnosis of myotonia congenita involves evaluating the clinical signs, electrodiagnostics, imaging, muscle biopsy, and genetic analysis. Neurological examination may reveal muscle dimpling upon percussion. While blood work, including muscle enzyme activity, is generally normal, magnetic resonance imaging and muscle biopsies may show mild and nonspecific changes. Electromyography, however, will demonstrate spontaneous myotonic discharges, characterized by a waxing and waning amplitude and frequency. Myotonia congenita has been reported in chow chows and miniature schnauzers and is linked to an inherited autosomal recessive trait. In cats, the condition has been reported only sporadically. These previous reports have focused on clinical signs, diagnosis, and genetic findings, with only one study discussing the use of Phenytoin as a potential treatment. This current report describes a case of a cat with myotonia congenita and how the cat responded to treatment with two different medications, Procainamide and Carbamazepine. This is particularly significant as there is a lack of information on treatment options for this condition in cats. The case report also aims to show how carbamazepine can be a safe and effective treatment option, contributing to a long lifespan for the affected cat. Case study, design and initial presentation. This study focuses on a 2-year-old female, intact, domestic shorthair cat referred to the neurology service at the Foster Hospital for Small Animals. The cat presented with a lifelong history of weakness, seizure-like episodes following excitement, muscle spasms, stiffness of the limbs, and shortness of breath. Initial diagnostics included a thorough history, physical and neurological examinations, and electrodiagnostics to confirm the myotonia congenita diagnosis. Other tests were performed including blood work, muscle biopsy and echocardiography to rule out other possible causes of the cat's condition. This process allowed the researchers to focus on addressing the primary issue of myotonia congenita. The physical examination showed a grade 1 out of 6 systolic heart murmur, muscular hypertrophy of the limbs and head, slight tongue hypertrophy and increased respiratory effort during periods of excitement. The neurological examination revealed a stiff gait, a kyphotic or hunched posture when stressed, a delayed palpebral reflex in both eyes, as well as increased generalized muscle tone and muscle mass. The remaining neurological exam was unremarkable. The cat's complete blood count and serum biochemistry analysis revealed mild hyperkalemia, which is a slightly elevated level of potassium, and hyperproteinemia, or high protein levels in the blood. Urinalysis showed the urine to be highly concentrated. Additional tests, including fasting total serum bile acids, the adrenocorticotropic hormone stimulation test, and total thyroxine, were all within normal limits. Thoracic radiographs, or chest X-rays, showed an enlarged cardiac silhouette and subjective hypertrophy of the body musculature, meaning that the heart was enlarged and the muscles seemed bigger than expected. Abdominal ultrasound showed a thickened diaphragm. An abbreviated electrocardiogram revealed low-voltage QRS complexes, but this test had to be stopped due to stress-induced cyanosis, which is when the animal turns blue from lack of oxygen. Echocardiogram results showed speckled hyperechoic regions of the papillary muscle, slight dilation of the left ventricle, trivial regurgitation of the tricuspid valve, and occasional premature ventricular beats. Electromyography. Electromyography was performed under general anesthesia, which showed the spontaneous waxing and waning myotonic discharges that are consistent with myotonic myopathy. Figure 1 displays the electromyogram showing the myotonic discharges. Part A of the figure shows the continuous waxing and waning action potentials from the insertion of a monopolar needle into the cranial tibial muscle. Part B of the figure shows the normal nerve conduction activity of the peroneal nerve. The nerve conduction velocity of the peroneal nerve was normal, which also made neuropathy an unlikely cause of the symptoms. A biopsy of the left cranial tibial muscle was taken under the same anesthesia. Figure 2 shows the biopsy of the left cranial tibial muscle. This figure shows the hematoxylin and eosin-stained cryosection from the muscle. The muscle showed an increased variability in myofiber size without other specific pathological changes. Immunostaining of the muscle for dystrophin protein was normal. This ruled out X-linked muscular dystrophy. Based on these findings, the cat was given a diagnosis of Myotonia congenita. Treatment and results. The cat was initially treated with Procainamide, an antiarrhythmic drug, at a dosage of 35 mg per kilogram by mouth every 8 hours. The cat showed some initial improvement with fewer episodes of stiffness and collapse for 2 months. However, upon reevaluation, the cat's clinical signs worsened, and serum levels of Procainamide showed significant fluctuations, with peak levels about 2 hours after administration, as shown in Figure 3. This figure shows the changes in Procainamide blood levels after an oral dose at multiple time points. Limited information is available on the metabolic rate of Procainamide in cats, but these results showed the serum levels increased quickly after administration to a peak within the human therapeutic range, which is between 4 and 14 micrograms per milliliter. The short half-life of 3 hours meant multiple daily treatments would be required, which was difficult. The dosage was then changed to an extended-release Procainamide at 37 mg per kilogram every 6 hours, and eventually, the treatment was discontinued after 2 years due to inadequate improvement. Given the unsatisfactory results with Procainamide, the cat was switched to Carbamazepine. Carbamazepine is an anticonvulsant that has shown efficacy in treating Myotonia congenita in humans. The Carbamazepine treatment was started at 8 mg, which is about 1.6 mg per kilogram, by mouth every 12 hours and increased by 4 mg every 2 weeks. Once the dosage reached 45 mg, which is about 9.8 mg per kilogram, every 12 hours, the cat experienced a recurrence of muscle spasms and limb stiffness. The dose was decreased to 40 mg, or about 8.7 mg per kilogram every 12 hours, resulting in a good improvement of clinical signs with minimal side effects. During the cat's annual recheck, an increase in the frequency of spasticity was noted. Because carbamazepine is known to increase its own metabolism in humans with chronic use, the dosage was adjusted to 50 mg, about 10.4 mg per kilogram every 12 hours. However, this resulted in a sudden onset of shortness of breath, limb stiffness, or previously unobserved flaccidity within 1 hour of drug administration and lasting for about 3 hours. Consequently, the dosage was lowered to 35 mg, about 7.4 mg per kilogram every 12 hours, leading to clinical improvement without apparent side effects. Over the next 12 months of recheck examinations, the cat showed continued improvement, with a decrease in muscle mass and increased mobility, flexibility, and athleticism. Episodes of muscle spasms and collapse were minimal, only 1 to 2 episodes a week, though a mild stiff gait and kyphosis remained. The spastic palpebral reflex also continued to improve until resolution with only occasional blepharospasm. 2 years after starting carbamazepine treatment, the cat's neurological examination remained stable, and it continued to do so throughout treatment. The cat was maintained on carbamazepine at 7.4 mg per kilogram every 12 hours for the remainder of its life, with no apparent side effects observed during yearly recheck examinations. 12 years later, the cat died at the age of 17 from unrelated conditions. Necropsy findings included moderate, multifocal cerebellar abiotrophy, which is degeneration of the cerebellum, and masses in the central nervous system consistent with meningioma, as displayed in Figure 4, as well as meningeal proliferative lesions. This figure shows the histopathological analysis of the cerebellar mass, revealing elongated spindle-like cells and psammoma bodies, which is consistent with the psammomatous meningioma. The iris of the right eye contained a mass consistent with lymphoma, and a mass in the muscles of the right forelimb was most consistent with a plasma cell tumor. The heart showed mild mitral valvular endocardiosis and moderate enlargement of the atria. Discussion. The presumptive diagnosis of myotonia congenita was based on the clinical signs, electrodiagnostic testing, and lack of specific myopathic changes on muscle biopsy. Limited information is available about treatment options and long-term outcomes for cats with this condition. This case report describes the cat's response to procainamide and carbamazepine. Class 1 antiarrhythmic drugs are the preferred treatment in humans with myotonia congenita. Procainamide and Mexiletine have been shown to have some efficacy in dogs with myotonia congenita. A previous case report of one cat with the condition showed a partial response to Phenytoin. In this case, the cat had an incomplete response to procainamide. After 2 months of treatment, the cat experienced a partial honeymoon effect with worsening of signs. The cat was then switched to carbamazepine. Carbamazepine is a dibenzazepine anticonvulsant, which enhances sodium channel inactivation, acts on postsynaptic serotonin transmission, and binds to other voltage-gated channels, such as calcium channels. It has been reported to be effective in treating myotonia congenita in humans. Several human case studies described within the article demonstrate successful management of the condition with carbamazepine, which also shows that carbamazepine is effective in treating stiffness and weakness associated with the condition. The cat in the study was maintained on 7.4 mg per kilogram every 12 hours of carbamazepine as a long-term dose. This resulted in no observed side effects and improved clinical signs. Carbamazepine induces its own metabolism in humans, requiring dosage increases over time. However, in this case the plasma concentrations were not available, but a dosage increase was not needed based on clinical signs and side effects. This suggests there may be potential metabolic differences between cats and humans. The optimal dosage and plasma level for controlling clinical signs in cats remains uncertain. Therefore, evaluating clinical signs and side effects, along with serum levels, is crucial for maintaining the drug within the desired effective range. The study notes that despite cerebellar abiotrophy observed on necropsy, there were no clinical signs observed at home or during routine examinations. It is currently unclear whether myotonia congenita contributes to heart anatomical changes or arrhythmias in humans, though low levels of CLCN1 are found in various organs, including the heart. Some reports suggest a possible relationship. The study also mentioned the absence of genetic testing and identification of a specific CLCN1 variant, which limits the ability to correlate drug effectiveness to a specific mutation. Feline genetic testing was also less advanced at the time of diagnosis, and there is no data on carbamazepine pharmacokinetics, dose range, or tolerance in cats with myotonia congenita. Conclusions. This case study suggests that carbamazepine is a safe and effective treatment for myotonia congenita in cats. The study demonstrates that it can be used to decrease the signs of myotonia congenita and contributed to a long-term survival of 12 years after diagnosis. Further studies are needed to evaluate pharmacokinetics and potential toxicity in veterinary species. Efficacy compared to other drugs in cats and dogs remains unknown and requires further research. Carbamazepine has shown positive responses when used to treat dystonia and dyskinesia in humans, which could indicate that it might be effective in animals with similar signs. Treatment of conditions affecting muscle tone and excitability, such as familial reflex myoclonus and Scotty cramps, with carbamazepine should be considered. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.